everybody. Good afternoon. Thanks for coming out today on a late Friday afternoon for a celebration. And it's a celebration of our alumni. And I think everybody knows why we're having this. Last year, we were recognized by the university. Our alumni were recognized by the university in an incredible way, and completely, no precedent, unprecedented recognition of the alumni of our school and the impact that they have on health here in the U.S. and around the world. We every year we nominate folks for some, not every year, but we choose and we nominate folks for university-wide awards. And last year, our alumni and folks affiliated with the school won 9 Johns Hopkins Alumni Awards. And this is the most that our school or any school has ever won in a given year, and it's a great recognition by the university of the quality of our alumni. So that's why we're having this little celebration today. What we're going to do is to have first start with a discussion that we have some panelists, but it's really a discussion of everybody in the room and an opportunity for us to talk. And I promised our panelists that you would help them do that. And I see that there are some members of the audience that I can count on to talk. Some emeritus members of the audience I know I can count on to talk. So we're going to have a panel discussion, a question and answer, and then we're going to have an award ceremony. And Nicholas Mathis from one of our alums who's on the who's our representative of the Johns Hopkins University Alumni Council, is going to do the awards and and introduce people. So you'll hear more about all the alumni then, and you'll hear more about our panelists. So I'll just tell you a little bit about them now. So first I'll introduce on the far side there, Dr. David Sirwata, who's the former dean at Makerere University School of Public Health in Uganda. And David is of course a graduate of our school, but someone who's been a leader in HIV research and in research education and training in Uganda. And then Jeff Crowley, who was here, I guess, earlier this year or last year, I can't remember.
Last year, I think.
Yeah, who's director of the White House Office of National AIDS Policy. And then in the middle, Margaret Kahn Himmelfarb. And all three are recipients of alumni awards. And I'm especially appreciative of Margaret's willingness to serve in this role, because Tara O'Toole was originally scheduled, and we heard late yesterday that there's a emergency in the Department of Homeland Security, and so she's not able to be here. So that's always a little worrisome when you hear that there's an emergency in there. But I'm sure there's emergencies every day. So Margaret, a special thank you to you. And I think probably most people in this room know Margaret, but she is somebody who has served the school for a number of years as a member of our IRB, and more recently a member of the Health Advisory Board to the school, and as a member of the board that advises the Center for Disaster Response and Refugees, and also for this, on the board of the Center for Public Health and Human Rights. So she just has made incredible contributions to making our school a better place. And as I say, when we give out the awards, Nicholas will do a more detailed introduction. So let's start. So what I asked the panelists to talk about is to start with just a brief description of what they think are the most important future health challenges, public health challenges. And they can name 3, 5, or 10. But to ask them they come with different expertise and different kinds of positions now, to talk about what they think are the important issues. So I'm going to ask Jeff if you would start first, please.
Great. Thank you, Dean Clegg. It's a pleasure to be here with all of you. I hate to say this, but I probably have to give you my disclaimer that I'm here in my personal capacity, not my official capacity. So these are just my personal opinions. So I'm not sure I'm even answering the question the way Dean Clegg is intending, but I guess from where I sit, I think about it as sort of what are some of the structural issues that I think are really important. And one, I guess, is how do we maintain community leadership in the work we're doing, and also, I guess, balance that with robust scholarship. And so In my role, we recently developed a national HIV/AIDS strategy, and we had a very robust community process. We had community meetings all across the country. And I think that type of thing is very important, and it's probably uniquely important in public health versus, business or economics. I mean, clearly consumer perspectives are always important, but I think when we talk about health, it's important. But I was also struck along the way at different points that, and we can probably all recognize this, that majority opinion isn't always right. So we want to listen to people in communities and value their experience, but we also need scholarship to, give us facts about what we need to do. And so I think one big issue is how do we keep communities engaged and supportive of what we're doing, but also blend that with research and evidence. Another thing, and again, this is grounded in where I sit, is that to affect policy change, it's not even always having the right policy as much as maintaining political support for what we're trying to do. And again, in thinking about, developing this national strategy, I would joke with my colleagues that, everything in my world is politically controversial. I mean, HIV is sex, drugs, and rock and roll. And, Dr. Holtgrave is here. He's on our Presidential Advisory Council on HIV and AIDS, and he knows some of this. So when we developed a strategy, we talked about focusing on gay men. We talked about focusing on black people. We talked about sex ed in school. We talk about state criminal laws. None of those are easy for our political system. It's easier to stay away from all of those. So we felt like we knew what's the right policy direction, but how do we maintain political support? And I think that's just a narrow example, but maintaining that support is really important. The third thing that I'd say is a lot of our best public health responses seem to be responses to emergencies. So how do we maintain or sustain a response when we're not, immediately reacting? And, from HIV's perspective in this country, we're entering our 30th year. And I think we've done a relatively good job, but there's challenges because some of the things you do immediately are harder to sustain, and even in meeting some of our prevention goals, probably some of our earlier successes were built on fear, and we don't want to go back to those days. And then the last thing I'd say is how do we maintain financial support? And again, this feels like, maybe I'm wrong, but compared to other areas, public health is uniquely challenged in sustaining the financing. And whatever the issue is, over the long term, how do you keep the American people or a broader public engaged on any issue? At the International AIDS Conference in Vienna this summer, I was struck by some comments made by President Clinton about how do we finance this. And he was talking about Bono's RED campaign and other things, how we need to move away from thinking that the solution is uniquely governments. And he was talking about sort of small aggregating funds where it's like, you get 10 cents with every financial transaction, and that has the potential to raise a significant amount of money. And I'm not saying that's the answer, but I think we're challenged in financing public health, and we need to think creatively about how do we sustain it. And I guess that's my sort of short list of what I think some of the challenges are.
They're great challenges. I mean, they're important challenges. I think you're right. And so they raise a lot of questions in my mind, but I think we'll come back to and open it up afterwards. So David Sawada, you work in HIV as well, but a whole host of problems.
Right.
What are your challenges?
First of all, I am very grateful for this opportunity, for this award. But before I start my remark, I really need to give my tribute to my teachers who are here in the audiences. I can see some. I was here during the time when Dean Alsama was on the dean. But I see quite a number of my lecturers, Ron Gray, Maria Weaver, who I think have done a great job of mentoring me, so I'm very grateful for that. So I think my gist is very much like the previous speaker. First of all, in order to really name the pressing challenges of public health as we see, particularly from Africa, specifically in East Africa, I think the most biggest concern are the ever-growing drivers of public health, which actually play. You see, all these diseases we see in public health or public health problems do occur in a context. And we find that this is now becoming extremely very important in either mitigating or actually the natural history of many of these problems. And I think one of the biggest problem, before I start to talk on the specific health problems as we see it, or public health challenges, is to look at the issues of governance, leadership, accountability, long-term planning. We have a crisis in any part of our world of leadership. And with it, accountability, and with it, proper planning. That sort of is a huge overarching problem that in which many of our public health problems foster or grow. We have issues of population growth. Africa, despite all the AIDS epidemic or many other infectious diseases, still has a huge population growth. My own country has a very high fertility rate of about 6.9 per woman. And we still have our annual growth rate of about 3.2. And this is fairly similar in many other African countries. Population pressure have actually put a huge strain on land, deforestation, which has had a huge impact on the environment. But people are ever looking for land. And in the process of looking for land, they're ever encroaching on environments that and encountering pathogens that they never used to encounter, which in itself generates huge public health problems, as I will discuss later. But the environment is also a huge problem. As the population growth does grow, we are seeing huge environmental changes, which in themselves bring about challenges. Many of you know of highland malaria, but also the degradation in itself is creating a huge health problems, as we shall see in future. These drivers, as we call them, therefore rapidly accelerate the emergency or re-emergencies of already big public health problems. You know, I'm always asked, and sometimes I reflect, and we always go through this exercise whereby we are said, you know, when you look in the next 20 years, 25 years, what do you think are going to be the main big challenges in health? And I'm like, when I look back 20 years or 25 years ago, what would I have thought would be the challenges today? Unfortunately, the further you go back, the further you know, and think of what the challenges are today, they seem to be the same. You know, TB, malaria was still a problem 25 years ago in our part of the world. It is going, I think, to still be a big problem in the next 10 to 25 years. What is going to happen is that the magnitude of this problem and the complexity of these problems is going to change as given by the drivers. We are going to have, I think, infectious diseases are still going to be a huge problem. And the rate at which emerging diseases is also going to be more rapid. And because of this exposure I've alluded to. But the most concerning thing is that the rate at which they will spread is also going to be very fast. To be sure, emerging diseases or diseases originating particularly from wild animal has always been there. It's just that the rate at which many of these episodes will be happening, the speed as a result of population growth, as a result of expansion of population, as a result of governance issues, environment is going to be much more rapid, and this is going to create a much more higher rate of emergence of these problems and exacerbating most of these problems. I mean, take an example of drug-resistant TB. We think it's going to be a huge problem coming forward. In the way back, 20, 30 years ago, this is something that would have slowly, insidiously spread in population. But with the population growth, the overcrowding, the rapidity at which people are moving, I think is going to create a huge panacea of how rapidly this problem is going to expand. So everything is going to be a little bit more accelerated. Drug-resistant malaria. This is going to be a huge problem for us. And unfortunately, the rate at which research is happening in terms of developing new anti-malarial drugs is not keeping up at the rate at which resistance is coming. I think resistance of pathogens is going to be a very huge problem in our part of the world as infectious disease, old and new, still expand in terms of burden and in terms of geographical locations. What is also becoming very clear is that while we have our eyes on the infectious diseases, which I think will still be a huge problem, we are seeing chronic diseases that are coming, but we are not keeping our eye on it as much as the infectious disease. But they are growing in terms of numbers, absolute numbers, but also in terms of disease pattern that is evolving in Africa. Cardiovascular disease. When I was a medical student, I never saw a single case of myocardial infarction. Never. There was none. But now, we are increasingly beginning to see most of these problems. And I think we are somewhat ill-prepared in terms of training, in terms of facility to meet some of these chronic diseases that I think are really coming onto the horizon. Coupled with that, I think we are having a health system which has gone down over the years. The health systems in many parts of Africa are really compounding the problem of our future health. Most of them are not only able to meet the growing demand and need of care of infectious disease, but they are poorly well equipped in terms of tackling the chronic diseases that we see coming. However, having made that soundbite, I think there are emerging possible solutions, and solutions that I think we could look at as a possible way of going through this problem. Institutions like ours, university institutions, I think could play a very leading role in terms of increasing the human resource training needs. But as my previous speaker pointed out, this requires a long-term investment. Unfortunately, most of our planning, both funders and many of the governments, are on a short-term 5-year strategic plans. But this is looking at a scope of terms of expanding the healthcare force. I think we are at the moment having, for example, a twinning grant which is helping us in terms of increasing our capacity to turn out healthcare profession between Makerere University and Johns Hopkins. So if we could build onto trainers of trainers to be able to increase the capacity of the human resource, that is going to be very important. Finances, as my previous colleague has pointed out, is a very big problem. But I think we need to develop for the future a new paradigm of how we are going to finance most of these challenges. We know, unfortunately, in many parts of Africa, much of these health problems are the solutions are mainly donor-driven, donor-funded. And there has to be a paradigm where we have shared responsibility between the host institutions and the donors in terms of having more responsibility and accountability put on African governments to be able to carry on much of this responsibility. Otherwise, in terms of the long-term financing of these problems, I really do not see a huge, really the donor being providing a solution to this problem. Going back to training, I think, and the roles of universities in meeting these future challenges, I think we are all yearning for evidence-based solutions to many of these public health challenges. And the universities have a critical role in terms of providing that evidence-based. There has been a lot that has been worked on, for example, in the areas of HIV between, say, Johns Hopkins and Makerere University. But just like in governance and in terms of tackling finances, we think that this partnership between the universities, say U.S. universities and African university, has to be a really genuine collaboration in terms of trying to tackle many of these health problems, or at least providing the evidence on how best to be able to tackle these challenges. And this should be a genuine mutual respect in terms of how this collaboration goes on, in terms of how we transfer skills, and I think that in the long run is going to provide a sustained base in terms of providing the human resource that we require. So I think for the moment I'll leave it at that, but I think that once again we need to tackle the structural problems in order to, before we really have to tackle the challenges of infectious and chronic diseases, at least in the long run, to have a sustainable framework in which we could be able to tackle this. Thank you.
So thank you, David. Lots of food for thought there, and for conversation about why there are these structural problems that persist. And you know, when you talk about the same issues as 25 years ago, but only worse, I was at a conference last week in Berlin, and there was a climate scientist talking about global warming. And he showed a film from 1959 done by Frank Capra, you know, who did It's a Wonderful Life, with a climate scientist talking about how we're poisoning the atmosphere, CO2 levels are going to build up, we're going to have global warming. And I think if, you know, before I heard that talk, I would have disagreed with you that the same problems as 25 years ago, because I would have said global warming wasn't really on the scientific agenda. But it was that way in the 50s. So, so our last panelist perhaps has the toughest job to go last, but just to say again, so Margaret is also a graduate of the school, and she has been a long-time advocate of science to improve health and rational science policy. Was involved with the JDRF for many years, and through her efforts in the School of Medicine, became a strong supporter of stem cell and stem cell technology. So she now chairs the Maryland Stem Cell Research Commission, which is an important part of how the state supports stem cell research. And you know, so Margaret, I'd like to hear your thoughts. You know, and I should say one other anecdote about Margaret is that when she became aware of public health and then took a course, she jumped in with both feet and got a degree. And while she was pursuing the degree, she was so passionate. Her daughter was visiting from out of town, and she encouraged her to come and sit in on a lecture. And then her daughter got an MPH. So it's a new infectious disease, you know, public health. So Margaret, your thoughts about the future challenges in public health?
Well, thank you. Actually, Elizabeth's interest in public health is the healthiest form of infection I know. I also want to talk about chronic diseases and expand a little bit on my fellow panelists' comments. And I want to use two examples, one I'm less familiar with and one more familiar with. And the first I'll talk about is AIDS, very briefly, sitting next to an expert, some nerve. And just want to say that even within a single disease, there are often competing needs for funds. And as most of you know, new cases of AIDS, of course, continue to arise. But the good news is, with improved, more available, less costly treatments, AIDS has basically become, in most instances, a chronic disease and no longer necessarily a death sentence. Because more people are living with HIV, and their growing treatment needs, there's a school of thought that treatment actually reduces viral load, and therefore, at least in some populations, the treatment, even without a change in behavior, can affect the rates of diagnosis. That is not necessarily true in all populations. I think it's probably still up for debate. And certainly treatment is a human right, but treatment could be competing with funds for treatment. And I think that is an important area that requires a lot of attention. There is a fabulous study that you may be aware of that was the PI was our very own Ron Gray, in Rakai, where he discovered that male circumcision significantly reduces the rate of transmission. And so treatment programs and prevention programs hold equal weight. And there are some policies and some provisions that have to be meted out with great wisdom and equitability. The second disease is type 2 diabetes, which was formerly called adult onset. It's been labeled by the World Health Organization as a global epidemic and has an astronomical cost in terms of not only dollars, but the human toll. And you may have read that the rates increase when people from countries with low incidence are transplanted into countries like the United States, that rates in developing countries increase as those countries become industrialized and adopt Western diets and habits, and that in this country it's fairly well known that due to diet and lack of exercise, the rates of type 2 diabetes have been increasing tremendously at a rapid rate, and particularly in children, where type 2 diabetes previously wasn't even seen. So the question is, what do we do? And so there are lots of thoughts, not really good answers, but prevention seems to me one of the best ways to save lives, millions at a time. I happen to know a little bit about type 2 diabetes, more about type 1, full disclosure, because I have a son who's had type 1 diabetes for 30 years, since he was 4 years old. And so I came into this school thinking cure, better treatments, and left understanding that prevention is something that really is possible today. We have to wait for science to catch up with better treatments and cures. But there's so much that we know today that it seems that earlier detection, more available detection, more effective detection is obviously a way that with diseases that go silent for many years, like AIDS and like type 2 diabetes, that we really can make huge inroads toward the mission of this school. A second thing is the knowledge that we have. Can we translate it to the populations who truly could take advantage of this? Can we educate the public about the risks? Can we reach the affected populations and find culturally acceptable ways to change behavior and to institute treatments? What can we do to push the development of best practices and new technologies, like genetics, screening, targeted treatments, something in the future, telemetry, distance medicine, where we could reach people in the hinterlands with treatments that we have now, robotics and diagnoses, and make them available to outlying populations. My other hat, stem cell research, which holds the promise of repairing tissue and actually creating new organs to replace damaged and injured and diseased ones. And most importantly, to advocate for best practices and best policies, which at least the best practices becomes very difficult in a culture where healthcare providers have even more limited time to lavish on each individual patient. And overarching everything, human rights, because in fact it is everyone's right to the best health care, and we need to find ways to efficiently, effectively, and equitably allocate the resources that we do have.
So, panel, thank you very much for your thoughts. I appreciate it. So let's start the discussion, okay? And burning questions. Can I go first? Can I go? So Jeff, I think your role, your portfolio is primarily confined to domestic policy. Is that right?
Yeah, I have
Okay.
some involvement in global, but a pretty small
Okay.
role.
So David brought up the issue about health systems, and that health systems are maybe even less able to deal with new and problems like chronic diseases, and that they're less flexible. And how much do you think since you don't have to worry about PEPFAR and international policy, and speaking as a private citizen, how much do you think these targeted programs like PEPFAR, which deal with disease, or other, silo-based programs, have influenced health systems in the developing world in terms of perhaps decreasing their flexibility to take on new problems?
That's, an interesting question, and I should, as you sort of framed it, I'm not an expert here, so some of this is sort of some level of ignorance. I actually think, well, first of all, to step back. So, we've had the PEPFAR program. Certainly President Obama believes it's a huge success, but he launched his Global Health Initiative.
Mm-hmm.
And this is about, focusing on neglected tropical diseases, other conditions. But I think a big focus is on building the capacity of health systems.
Mm-hmm.
And the first thing I would say is the only reason that this conversation is even happening is because of the success of PEPFAR.
Mm-hmm.
So I don't think it's that PEPFAR has sort of restricted the flexibility of these health systems. I think it's created new opportunities.
Mm-hmm.
But I do think, we're challenged in how long can we maintain such a strong focus on one condition or set of conditions. So
Mm-hmm.
even with our Global Health Initiative, if you've read the newspapers recently, you know that the President's been criticized for the direction we're moving. But even with our Global Health Initiative, at the end of this first 6-year period, 70% of our global health spending will be for PEPFAR,
Mm-hmm.
so HIV/AIDS and the other conditions. So I think that even that is a challenge to sort of maintain such a sole focus on that.
Mm-hmm.
But I do think that because of the success, again, in this one disease area, it's actually created opportunities, not limited flexibility.
Mm-hmm. Okay, great. So let me ask, David brought up about a financial services tax, right? Which is a very popular, did Jeff bring it up or David? I can't remember, but a tax on financial services to fund, HIV prevention and treatment and other problems in the developing countries. And, it's very attractive because one, it's not our ox being gored, right? It's financial services. Banks are unpopular financial services. And in the UK and other European countries, they call it the Robin Hood tax, right? And it's a very appealing. You take from the rich, you give to the poor. But I'd like the thoughts on how, whether you think that's really something that can move forward. Is that really a feasible approach, or just another way to bash financial services? Do you think that will ever come to pass?
Mike, did you say taxes on financial services?
Yeah. So there's this proposed tax. I forget the name of the man who it's got an eponym, but it's also called the Robin Hood tax, where you look at stock transfers, financial services, and you take a penny or you take 2 cents.
To be sure, I really can't talk to that.
No?
I'm not aware of that.
So you guys have heard of this, right? Yeah. So Bob Lawrence is raising his hand. Are you raising your hand, Bob?
I want to frame it slightly differently, Mike. 20 years ago, when Jim Grant was head of UNICEF,
Yeah.
he reminded the world that the UN system had made a commitment to have rich countries provide 0.7% of GDP. So in your nice way of looking back 25 years, and here we are, I don't think, except for a couple of the Nordic countries, that anybody has hit 0.7%. What do you think it looks like 25 years from now?
I must say, I spent the last 2 days in London, and I was very impressed. England, UK is undergoing a austerity measure budget,
Mm-hmm.
and they have cut everything. But what actually struck me is that actually their overseas expenditure aid was increased by 37%. And they kept asking the Chancellor why he's doing this when he's cutting everything home, because he wanted to make that target of 0.7% of his GDP. And he wants to send a message, yes, although we're suffering, but we'd like also to help out the other people. So that was a very striking observation when I left London yesterday. Yeah, he increased aid despite all these causes. Many, as you know, whether it's G7 or G20, have not met this. and it has been an always ever increasing problem. But so do actually African countries. African summit in Abuja said every government should spend about 15% of their national budget on health. And, neither many of these countries, hardly, probably 3 countries have been able to do that in the last 5 years. So I think this is, as I used the word shared responsibility in one of my submission, I think African governments will also have to realize that if they are going to we are going to get out of this problem, we have to invest our own resources. We have to plan in the long term in terms of, and this is where it gets, actually, the more I think about the future challenge of public health is on leadership. You could talk about infectious disease or chronic diseases, but actually it's on the leadership of many of our governments to be able to actually provide the resources, the long-term planning to meet many of these challenges. Because it seems to me that many of these challenges, this is the whole big overarching problems why not only are they still there, but they're also growing worse. So I think it's going to be the donors. I think Africa at least need to realize that, you know what, the donors are not really going to help to commit ourselves, to help themselves to really be able to commit to what they are saying. They have to do it themselves. The sooner that we realize that, and that's where the leadership has to come from, to be able to do something. There could be some policies that could be put in place that could really push us a little bit further. To be sure, many African countries are not necessarily very poor, but it's just a question of how they really prioritize and organize themselves to be able to create the environment or tap into the resources they have in a very meaningful way. So to me, I see that that is the only way that we are going to get out of this, this hole.
Mm-hmm. Jeff?
Yeah, I want to respond and maybe be a little controversial. Maybe that works in the British political system. I actually just don't see this sort of percentage goal as animating any U.S. politicians. And I also wonder, if we think about why we have these goals, I think it's really about motivating people to give something. So I think if, maybe we need other measures. So, we tend to think a lot of our problems are easier to solve if our economy grows. So what if we, had a great period of economic growth, and so it created more opportunities for funding, but if it's a percentage, then it's like the expectation rises. But I also think that, it also doesn't give any credit for policy. So some of the great things that are happening through PEPFAR are great because of the dollars we're giving, but also just think about, the policy work, the Clinton Foundation and others about negotiating drug prices, and those have to weigh in too. And it's not that I'm saying this percentage goals don't matter, but it just feels like if you're sitting trying to motivate a politician to care, that one feels like it's hard to get ahead of the curve, whereas they never get credit for doing good things.
Yeah, well, I think, it's in a sense a moral argument, right? And I agree, moral arguments don't work well with our politicians. They just, it's a cultural thing, I guess. So, yeah, Al?
So I have two questions, but I'll start with one and then come back to the other. So all 3 of our distinguished speakers talked about the problem of, on the one hand, increasing chronic diseases on top of existing infectious diseases, and that's infectious diseases everywhere, particularly chronic and at the same time, public health doesn't get any respect. So Mike and I, although we were in different parts of the room, I couldn't see you because I wanted to sort of wave and laugh. We heard an address over lunch from the distinguished leader of the Johns Hopkins Medical Center, who started to explain to the audience what healthcare reform was all about and how they had come to this brilliant realization that they were responsible, the health system, for the health of a community, and if they were not going to get broke, they were going to have to prevent diseases.
Right.
I thought, whoa, I mean, hey, finally the dean of the medical school's gotten a little public health. So do you think that HIV, for example,
and the need to provide all this treatment for people, although I must say I haven't seen it as a response, would jimmy up a response on the part of governments, whether they're African or the U.S., to pay more attention to prevention and public health. I mean, I haven't seen it played out in terms of dollar signs, but here I'm seeing a healthcare system that has to meet its bottom line, saying, gee, we better essentially get some more public health messaging going here if we're going to be able to stay in existence.
Oh, I could start tackling that. To be sure, yes, there has been a substantial increment in investment in HIV through PEPFAR, no question about it. But when I start by looking at Uganda, PEPFAR brought in a substantial amount of resources. That trickled down to the village. People are living who should have died quite a long time ago. I have not seen, however, an equal amount of investment by the government. If anything, it could have generated some complacence in terms of funding. And neither do we see substitution. In other words, the government saying this money could have gone in HIV instead of putting it in HIV, since there's this X amount of dollars coming in, let's put it in maternal child health. And therefore be able to sort of beef up that area. No, what we have seen is that to begin with, the funding hasn't changed as percentage of budgets. And if anything, what is actually pronounced at the beginning of budget time is not what they eventually get. So to some extent, HIV, the money, which everybody is very grateful for, has not really got the government thinking that, look, this is not going to be there all the time. I mean, we have to think about how we are going to look at our own human resource, how we're going to look at where are we going to, I mean, Uganda, for example, has a factory which produces ARVs, but they are almost open shut, because they do not have governments to buy the drugs. And therefore, yes, there hasn't really been that attention to the to really, you know, looking at the future, which goes back to leadership. I can tell you that if these resources eventually dries up, which it will still catch us with our pants down.
So it's a similar observation that Jeff made, that, you know, in the case of Uganda, it's not their money. So there's not the pressure that the medical center is feeling to meet the bottom line that's pushing them towards prevention. But it's a similar issue to what Jeff brought up about, you know, it's human nature that we deal with emergencies, and then when something goes from becoming an emergency to a chronic disease, suddenly we're not as interested. So I've been told that to please use the microphones on the sides, because we're taping this, and so to have a tape that people can podcast that we can use on the web. So there's a mic on each side. Just stand, and so, sir. Yeah.
Yes. My name is Art Cohen. I'm a graduate of the school a number of years ago. I have to say that what Dr. Sawada said about things not changing in the last 25 years, actually, I think we can go back a lot further when we look at something that we all take for granted, most of us in this room, which is sanitation. The sanitary revolution, so-called in public health, of 100, 150 years ago has not been finished. As we all know, 4 out of every 10 people in the world do not have decent sanitation. So I'd like to ask the panel why you don't, whether you think this is one of the next great challenges of public health, which is to finish what it started in the global north and take it to the global south.
So sanitation. So I have to say that I met Art soon after I became dean, and he has repeatedly emphasized, I think accurately, this issue to me. So now he's bringing it to you.
Yes. Now, I completely agree with you. It's still unfinished business, and it's still a huge problem. And I'm here to say it will become even a bigger problem as population growth increase. When you look at urbanization and slum areas in many African countries, there's a huge urbanization. It's a bit like you see a refugee situation in slow motion in terms of how these squatter dwellings are coming up. And of course, one of the biggest problems there is sanitation. And of course, you know, in some urban setting, the under 5 mortality is much higher than in rural areas.
Right.
In fact, there's this issue of equity gauge. This is actually many kids in urban setting tend to have poor indices than people even in rural areas in the same country. So I think, yes, this is going to be a huge problem driven by population pressures. And I think this goes back to the only way probably is going to be better provision of sanitation. And this is something that falls usually in the ministries of water and environment, completely outside the Ministry of Health. And that's why you need that overarching leadership. It's going to be a big problem. We shall still talk about these diseases of poor sanitation for the next 25 years, unfortunately.
Margaret, did you
I
want
was
to
going to backtrack, if I may, and just say, add an addendum to Al's question, and that is, I think in the United States we're really not set up very well. We're not rewarded for prevention, in that prevention is a function of future rewards. And it seems that our politicians want short-term results so that they have statistics that get them reelected, positive statistics. We don't do the best job that we can educating them as to which policies are the best. They have health aides, but they're experts who come from places like this school who really need to be out there more and spreading our gospel. And the insurance companies, at least as they've been structured historically, look to lower their costs in the present. And the fact that prevention is a cost cutter isn't relevant to them, or at least, as I say, the system was set up because they expect that somebody will be with another insurance company if they don't prevent the disease, and so it'll be someone else's problem.
Yeah, a good argument for a one-payer system. Yeah. So Lou, is that you? I can't see.
Yes,
the whole-
Louis Faison from Southborough, Massachusetts. And I'm also a graduate, just a couple years ago. And I happened to be in a bookstore recently with my wife, who's over there, who's sitting over there. But I was looking at a book, and the book was about girls' education in Africa. And it actually was in Malawi, in a school that was started in Malawi. And I opened up, I was reading through the book, and it turns out the school was started by Madonna. And so I'm wondering, is Madonna ahead of the curve on this as far as girls' education in Africa? Or is there something there that we're missing out? How important as a challenge and a future payoff would girls, young women's education in Africa be for public health?
There is a very common phrase called girl child, which is a very popular catchphrase that we always use in our part of the world, i.e. to try to pay attention to the issues of girls, which eventually will pay dividends in terms of health. I think there's some truth into that. Madonna and others, I mean, who is the talk
Oprah.
show? Oprah has opened up.
That I know.
Have all chimed in to open up schools focusing on girls. First of all, to try to, girls always tend to be left behind in education in terms of the value system. Families tend to value training, educating males. So there has always been a problem of trying to bring up education, trying to empower women through education for better outcomes, health, financial, and so forth. So to be sure, I think to the extent that actually governments have also tried to introduce universal education so as to get really more girls in schools than they would have been otherwise, I would like to think has some impact on both in terms of eventually educating girls and having some kind of uneven footing, at least from the start. To what extent has this there have been some midterm evaluation of many of these efforts, and many of them show that, yes, trying to educate girls, you improve outcomes eventually. What you really need to do is to do this on a big scale and sustained over a period of time. To the extent that, pop stars and, ladies of means have been able to pay attention or bring attention to this issue, I think has been able, as a strong advocacy tool, it has helped. However, it has also created some controversies on the other hand. There has been, so it all depends on the approach. Madonna in Malawi initially started the adoptions, which has created a lot of issues. But also, I think you need to do it in such a way that you do not, because there have been some programs whereby they have actually been even trying to pay girls to stay in school. So in which case you are really now skewing, it's as if it's now an income generation to be in school. So it has to be done in such a way that, first of all, there's going to be a long-term sustainability of these programs so that you're not in for 5 years or 10 years, just, train 100 or 300 girls and leave it. And also that it has, to a large extent, has much wider impact in terms of the number of people that can access it. But otherwise, it's a worthwhile program if you do it in consultation with the governments and the health officials within the country, as opposed to coming in and just setting up a school and donate something and then, go. I think much of the problem has been the entry points into the countries and how this is sustained over the long run.
Great. Okay, so I think we'll take 2 more questions and then do the award ceremony. So Catherine, perhaps next.
Catherine Skanke-Glacius, and yes, I'm an alumna of the school, and I appreciate you talking about this multi-sectoral approach to get to the health outcomes, certainly with education as well as economics. And one of the things that I found when I was working with USAID a few years ago and went out on a PEPFAR visit, I remember, to a military hospital in Tanzania. And one of the physicians I was talking to, one of my obligatory themes was, how is everything going with adherence counseling for the antiretroviral therapy with the patients? And he was saying, well, it's going fine, but the thing is, we have a lot of just economic desperation here. So yes, people are living and they're surviving longer on the ARTs, but they get up and they don't have a job and they don't necessarily have the food to feed their families all the time. So he said that this poverty was still the underlying issue, and so while we're putting all of this money into the medical care, it still seems to me like at the front lines they're saying that's not the total answer. So I just wondered if you could say something about maybe other donors and other things that are going on in Uganda specifically about working to use some of the health dollars to increase that employment. And I know we've talked a lot about task shifting and things like that with health workers. Do you have any success stories that you've seen or any models that you've seen that do that better so that we're employing more of the people with some of the health dollars to help both sides?
To be sure, there's also a lot of stories whereby people have been on antiretroviral drugs and they are able to go to farm, to do agriculture. In other words, people have looked at, all they have been studying households, what are the HIV impact on household incomes. And, from just talking to people, yes, people, who would otherwise, especially the men or, whoever is the breadwinner who is on antiretroviral is more active, brings in more income into the country. In other words, it is making a positive contribution to the macroeconomics at the household level. I think to that extent it has really been contributing to people's households and being able to educate the household. As to well, I'm on antiretrovirals and I don't have a job, I think there's always going to be a proportion of people who will be on antiretrovirals who won't have a job anyway. But I think on the balance, I think it has kept people more active and more, income, be able to generate incomes. But to be sure, there are some studies that are actually looking at this and to have some evidence-based outcomes. But most of what I see is that, or what I hear is that it's more playing a more positive contribution to the incomes of household than otherwise it would have been the case. But nutrition, there are many problems, and I don't think PEPFAR is going to solve all the problems. But at least I think trying to put people on care has been a huge help, other problems notwithstanding.
Thank you very much.
So last question.
Hi, I'm Ruben Del Prado, a graduate in 1988 from this wonderful school. There's this tripartite of science, knowledge, and evidence, and politics, and politicians, and public health outcomes. And this tripartite needs a bridge from science to public health outcomes. And the politicians in the history of the world are the block on that bridge, to bridge, from science to public health outcomes. So my question is, how do we as public health practitioners in any part of the world, and especially when you come from Hopkins, because we're the smart ones, build those bridges between what we know, evidence-informed planning and things that we want to accomplish in public health outcomes, and using the politicians and the politics that is now an obstacle as our conduit. I mean, Al's question about, we know that prevention saves lives, and we know, I work for UNAIDS, that for every 3 persons you put on treatment, 5 become infected. So the prevention outcome is essential. You cannot treat yourself out of the HIV pandemic. Prevention outcomes are imperative. So my question is, how do we massage these politicians so they become us to get these public health outcomes that we know are essential, and they're no longer the blocks, and they become the leaders, as you mentioned, David. And great seeing you again. We met each other in Uganda many years ago, to become partners.
So let me ask Jeff to address. Jeff is the person who's in government, right? And so from the inside, what's your insight about?
Well, I'm not sure I have the answer for you, but I do think that evidence matters. Certainly, I believe, like in the case of President Obama, he is someone I feel like if you have data for him, he was prepared to go boldly in certain ways. So, it's not easy. The issue of absence-only sex education, not an easy issue, but we have data to suggest that absence-only doesn't work, and so I think he's very comfortable, and I could cite examples. So I think that really matters, but the thing is, we're not them, and we don't have to make the tough choices. So we can always say, yeah, well, we just need $20 billion more money, we need all these things. They do have to make tough choices, and it's always about these trade-offs. So I think part of what we need to do is figure out if we want them to focus on outcomes, we need to help them make those trade-offs and not just pretend that it's an easy decision for them to just do X, but frame it in the context of how you're balancing different trade-offs.
Great. Okay. So I'm going to ask the panel to take your seat, and thank you for a job well done. So we're not quite done yet. When I travel around the world, people ask me why we're such a great school of public health and how we maintain our position. And I say it's because we get great students and they become great alumni, and they make us look good around the world. So this is a day where we want to celebrate the achievements of our alumni and people who have affiliated and supported the school. So I'd like to ask Nicholas Mathis to come up. He's going to be introducing our awardees. Okay. Nicholas received his MPH from the school in 1998 and has been affiliated and a supporter of the school since. He has served on the JHU Alumni Council for 6 years, and as part of the council, he is also a senior member of the Awards and Nominations Committee. And for Nicholas.
So, okay, we'll get started. I think it's in alphabetical order. So the first Recipient is Hideyasu Aoyama, winner of the Distinguished Alumnus Award. The Distinguished Alumnus Award honors alumni and friends of Johns Hopkins who have typified the Johns Hopkins tradition of excellence and brought credit to the university by their personal accomplishment, professional achievement, and humanitarian service. Dr. Aoyama was not able to travel to the US to accept the award due to ill health. The Dean will be accepting this award on his behalf. Dr. Hideyasu Aoyama is a public health hero in his native country of Japan. He is a pioneer in the field of occupational health and worker safety, and until his retirement in 2003, managed the directors of every preventive medicine department in all Japan's medical schools. He founded the Department of Hygiene and Preventive Medicine at Okayama University Medical School in 1980, growing it into the largest department of preventive medicine in the country, and later served as president of Kochi Women's University, the premier Japanese women's institute for nursing and health. Dr. Aoyama has been outspoken in promoting public health in Japan, writing over 200 articles for journals and magazines, including the Bloomberg School-owned publication, Johns Hopkins Public Health. Dr. Aoyama's boundless energy and selflessness in his efforts to improve the health of Japanese workers and the general public, to educate his students, and to establish and improve communications between Japan and the international medical community make him worthy of the Distinguished Alumnus Award. Okay, great, okay. Okay, Jeff, the next, Jeff Crowley. Jeff Crowley, winner, the Woodrow Wilson Award. The Woodrow Wilson Award honors alumni who have brought credit to the university by their current or recently concluded distinguished public service as elected or appointed officials. Jeff Crowley was confirmed as director of the White House Office of National AIDS Policy in February 2009. He coordinates the federal government's efforts on HIV/AIDS policy and guides the administration's development of disability policies. The office emphasizes prevention through wide-ranging education initiatives and also helps to coordinate the care and treatment of citizens with HIV/AIDS. The office also coordinates with international bodies to ensure that the fight against HIV/AIDS is fully integrated around the world. Crowley has authored numerous reports and policy briefs, and he has testified before various congressional committees on several occasions. Previously, Crowley was a senior scholar and researcher at the Institute for Health Policy at Georgetown University, where he focused on Medicare and Medicaid policy from 2000 to 2009. Lynn Eckert, winner, Distinguished Alumnus Award. The award honors alumni and friends of Johns Hopkins who have typified the Johns Hopkins tradition of excellence and brought credit to the university by their personal accomplishment, professional achievement, and humanitarian service. Dr. Eckert came to Johns Hopkins as a Robert Wood Johnson Scholar. After leaving Hopkins, Dr. Eckert began her academic career at the University of Massachusetts Medical Center as an assistant professor in the Department of Family and Community Medicine, moving through the academic ranks to full professor and eventually being appointed department chair in 1984. Along with serving on numerous boards, including the school's own Dean's Alumni Advisory Council, Dr. Eckert has been a visiting professor and Cabinet Trust Scholar in the Department of Community Medicine at the University of Zimbabwe and a visiting professor of the University of Cape Town Department of Pediatrics. She currently works as the Director of Academic Programs for Partners Harvard Medical International and regularly travels to Lebanon, where she collaborates on the founding of a new medical school with the Lebanese American University, and the UAE, where she helped to develop the governance and regulatory structure for the world's first free healthcare zone.
And so Lynn told me on the way that she's now the acting dean of the Lebanese American
Dean Gudemout, winner Heritage Award. The award honors alumni and friends of Johns Hopkins who have contributed outstanding service over an extended period to the progress of the university or the activities of the Alumni Association. Dean Gudemout's dedication to the Johns Hopkins University and the Bloomberg School of Public Health has been immense, bringing his high energy to both the Health Advisory Board and to his chairmanship of the Advisory Committee for the Center for Refugee and Disaster Response, where he founded the Gudemout Humanitarian Award and its accompanying scholarship for exceptional students pursuing an advanced degree in international public health. The first scholarship was given in 2008 to Sana Malik, a Jordanian student. Margaret Kohn-Himmelfarb, winner Heritage Award. Honors alumni and friends of Johns Hopkins who have contributed outstanding service over an extended period to the progress of the university or the activities of the Alumni Association. Margaret Kohn-Himmelfarb is a member of the Johns Hopkins Bloomberg School Health Advisory Board, Dean's Alumni Advisory Council, and the advisory boards of both the Center for Refugee and Disaster Response and the Center for Public Health and Human Rights. She sits on the Bloomberg School Institutional Review Board and the Johns Hopkins School of Medicine's Embryonic Stem Cell Research Oversight Committee. She currently chairs the Maryland Stem Cells Research Commission and is a member of the Juvenile Diabetes Research Foundation's International Board of Chancellors and Clinical Affairs Workgroup. She and her husband have established the Richard J. and Margaret Kohn-Himmelfarb Student Support Fund, which supports graduate students at the school, with preference given to students who are pursuing a doctorate in autoimmunity or other areas related to diabetes, particularly type 1. The fund supported its first student in the fall semester of 2008. Okay. Roger Lippitz, winner Heritage Award. The award honors alumni and friends of Johns Hopkins who have contributed outstanding service over an extended period to the progress of the university or the activities of the Alumni Association. Mr. Lippitz is a former chairman of the boards of the Baltimore Development Corporation, the University of Maryland Medical System, and Meridian Healthcare. He has served as president of the American Healthcare Association, the largest long-term care association in the United States, and as president of the Health Facilities Association of Maryland. The Lippitz Family Foundation, established by Roger C. Lippitz Research and Policy Center for Integrated Healthcare and the Eugene and Mildred Lippitz Professorship at the Bloomberg School in September 1998. The center provides critical health services, particularly as they relate to post-acute and rehabilitative care. Its multidisciplinary activities span the schools of medicine, nursing, and public health. In May 2000, Mr. Lippitz was elected to the Johns Hopkins University Board of Trustees, where he is the chair of the Finance Committee, and is currently the chair of the Bloomberg School's Health Advisory Board, where he directs the school's fundraising efforts. Tara O'Toole, winner Woodrow Wilson Award. Honors alumni who have brought credit to the university by their current or recently concluded distinguished public service as elected or appointed officials. Unfortunately, Dr. O'Toole cannot be with us this afternoon due to unforeseen circumstances at the Department of Homeland Security. Dr. Tara O'Toole was confirmed as Undersecretary of Science and Technology at the Homeland Security Department on November 4, 2009. Her previous government experience includes 4 years in the Clinton administration. From 1999 to 2003, she managed the Johns Hopkins Center for Civilian Biodefense Strategies, which aims to reduce the risk of biological attacks, epidemics, and other destabilizing events, and to improve the nation's resilience in the face of such events. For the last 6 years, she has served as the director and the chief executive officer of the Center for Biosecurity at the University of Pittsburgh. Rajesh Punjabi, winner Outstanding Recent Graduate Award. Honors recent graduates of Johns Hopkins within 10 years of graduation for outstanding achievement or service in the professions or volunteer life. Raj is currently working in Africa and cannot be here to accept the award, but his wife, Amisha Raja, the co-founder of Tiatian Health, will be accepting the award on his behalf. Rajesh Punjabi is co-founder and director of an NGO dedicated to providing healthcare services in one of the poorest areas of Liberia. Tiatian Health works on issues such as HIV/AIDS, malaria, tuberculosis, and mental health, and helps train healthcare workers and equip local health centers devastated by Liberia's civil war. It is also involved in both advocacy and fundraising, earning grants from organizations such as the Clinton Foundation and the United Nations High Commissioner for Refugees to bolster social justice in rural Liberia. Despite the organization's relatively short existence, it has already made impressive inroads into improving the health situation, establishing one of the largest rural AIDS clinics in Liberia, a community-led initiative that provides treatment and care for over 300 HIV/AIDS patients, trained non-physician clinicians to administer antiretroviral therapy, published a groundbreaking national mental health study that revealed that over 40% of Liberian adults are affected by post-traumatic stress disorders and depression, built Liberia's first chronic disease clinic, hired medical staff, and distributed insecticide-treated malaria beds nets to local villages. David Sawada, winner Knowledge for the World Award. Honors alumni who exemplify the Johns Hopkins tradition of excellence and have brought credit to the university and their profession in the international arena through their professional achievements or humanitarian service. Dr. David Sawada is a Ugandan academic, scientist, researcher, and civil servant based in the capital, Kampala. He first identified the slim disease as AIDS in Uganda back in 1982, when little was known about how the disease was caused or that there was any connection with reports coming out of the US about similar symptoms. Over the next 18 years, the Rakai Health Services Science Program secured funding from numerous US and international organizations, including the Johns Hopkins Bloomberg School of Public Health. The program has determined that viral load is a key determinant in the likelihood of transmission, reducing sexually transmitted diseases that does not lessen HIV incidence in communities with a mature, generalized epidemic, and that circumcised men are 60% less likely to be infected by HIV. As a result, USAID has made circumcision part of their prevention package. The program now provides 5,000 HIV-infected people with prophylaxis against infection, monitors them, and provides them with antiretrovirals, and now has more than 400 employees, all but 2 are Ugandans, and a new 2 million research center that allows important lab work to be done on site. Dr. Sawada's role was to coordinate the research being carried out in Uganda and to act as the principal investigator. He later became professor of public health and dean of Makerere University School of Public Health. In the 1990s, he was also appointed director of then Makerere Institute of Public Health until his retirement earlier this year.
Thank you, Nicholas. That was great. Thank you for everything you do for the school. I also want to thank Philippa Moore, who was the person up here helping me. She is the Director of Alumni Relations for the school and was the person who organized this, was instrumental in carrying it out. So. And also everybody in the Office of External Affairs who contributed. So Thank you, where'd he go? Nicholas? So thank you for coming from Philadelphia, and especially for being an advocate for us at the Broad University Alumni Council. We really appreciate it. So now I invite you to a reception down in Feinstone Hall where you can come and interact with the participants and follow up on some questions that I know you wanted to ask. Okay, so thanks for coming.